Margaret is 74 years old, a widow from Pennsylvania, and for nearly 6 years she took her blood pressure pill exactly the way she was told. Same time every morning, glass of water, no missed doses, no guessing, no experimenting. She trusted the prescription, she trusted the process, she trusted her doctor. And for a long time, nothing seemed wrong. But then her son started noticing changes that did not feel small. This was a woman who used to be out in her garden before the sun was fully up. She used to take long walks after dinner. She used to say yes when the grandkids asked her to come outside. Then slowly, almost so slowly that nobody could name the exact week it began, her world started shrinking. By late morning she felt spent. She stopped going to church socials. She started sitting down halfway through simple chores. One afternoon she stood up from the kitchen table and had to grab the back of a chair because the room tilted under her. Her pulse when her son checked it was 48. Everyone around her said the same thing older families say every day. Maybe this is just aging. Maybe this is what 74 feels like. Maybe she needs to slow down. But here is the truth that changed everything for Margaret. Sometimes it is not age stealing your energy. Sometimes it is the medication meant to protect you, quietly, gradually, one dose at a time. And that is why we need to talk about two of the most commonly used blood pressure medicines in older adults, Amlodipine and Metoprolol. Because when someone says, "My blood pressure pill makes me feel weak," those two names come up again and again. And the question almost nobody asks clearly enough is this: between Amlodipine and Metoprolol, which one is more likely to drain your energy, and which one is actually the safer fit for an aging body? The answer is more nuanced than most people expect. And if you or someone you love is over 60, this is one of the most important medication conversations you can have. Before I compare these two drugs side by side, you need to understand one thing first. The same pill does not behave the same way in a 72-year-old body that it behaved in a 42-year-old body. Not close, not even a little, because aging changes the entire landscape that medication enters. Your arteries become stiffer. That matters because the top blood pressure number, the systolic number, becomes harder to control as you get older. It also becomes the number most strongly tied to stroke risk, heart strain, and loss of vascular resilience over time. Your liver may process some medications more slowly, your kidneys may clear them less efficiently, your nervous system may respond more sluggishly when blood pressure suddenly drops, and your heart may become less forgiving when a drug pushes the pulse too low. That is why a medication can look perfectly reasonable on paper and still feel terrible in real life. It is not always because the drug is wrong. Sometimes the dose is wrong. Sometimes the timing is wrong. Sometimes the drug is right for one diagnosis but wrong for the body now carrying it. That is the lens you need for everything that follows. Let us start with amlodipine. Amlodipine is a calcium channel blocker. That phrase sounds technical, but the action is actually simple. It relaxes blood vessels. More specifically, it helps reduce the tightening of the smooth muscle in artery walls, which allows those arteries to widen. When the vessels are less constricted, blood flows with less resistance, and blood pressure falls. For many older adults, that mechanism matters a great deal. Why? Because one of the biggest drivers of high blood pressure later in life is not always an overactive heart. It is often stiff, less elastic arteries. Amlodipine works directly on that problem. It does not primarily slow the heart down. It does not usually reduce blood pressure by making the heart pump dramatically less. Instead, it lowers resistance in the blood vessels. That is one reason calcium channel blockers are commonly used as first-line options in uncomplicated hypertension, especially when systolic pressure is the big issue. U.S. guideline summaries list calcium channel blockers among the standard first-line medication classes for primary hypertension, AAFP. For an older adult with stubborn high top number blood pressure and no major rhythm problem, no recent heart attack, and no special reason to slow the pulse, amlodipine often makes intuitive sense. Now here is where people get misled. They hear that amlodipine does not usually slow the heart very much, and they assume that means it is automatically the gentler drug. Not necessarily. Amlodipine has its own price. The most common complaint is swelling, especially in the ankles and lower legs. This is a well-known side effect and one of the most common reasons people dislike the drug. NHS. And if you are younger, you may hear ankle swelling and think of it as annoying but minor. But for an older adult, it can be more than cosmetic. Swollen feet change balance. Heavy legs discourage walking. Walking less weakens muscles. Weaker muscles increase fall risk. That is how one side effect turns into an entire chain of decline. Some people on amlodipine also notice flushing, lightheadedness, or a sensation of pounding in the chest. Not everybody, but enough people that it matters. Now let us turn to metoprolol, because this medication works through a completely different doorway. Metoprolol is a beta blocker. Instead of focusing mainly on the blood vessels, it acts largely on the heart. Your heart responds to stress hormones like adrenaline through beta receptors. Metoprolol blocks much of that signal. As a result, the heart beats more slowly and often with less force. That can lower blood pressure. But more importantly, it can also protect the heart in people who genuinely need that effect. This is the part that often gets lost in everyday conversation. Metoprolol is not just a blood pressure pill. It is also a heart protection medication in the right patient. It may be used when someone has had a heart attack. It may be used in certain forms of heart failure. It may be used for angina. It may be used in some rhythm conditions where slowing the heart is useful. Those are real, meaningful reasons. NCBI stat pearls. So if you hear that metoprolol can cause fatigue, that does not mean it is a bad drug. It means it is a powerful drug with a very specific personality. And when that personality matches the patient, it can be extremely valuable. But when it does not, the side effects can quietly take over a person's day. Because if a medication lowers your heart rate more than your body comfortably tolerates, the result may not feel dramatic at first. It may just feel like life getting dimmer, less drive, less stamina, less interest in doing things that used to feel easy. The tiredness people describe on metoprolol is often not normal tiredness. It is not, "I had a long day" tiredness. It is a kind of heaviness, a flattening, a sense that your body no longer wants to rise to the level your mind expects. Dizziness can happen too. Slow pulse can happen. In some people, especially if there are other medications involved, the heart rate can drop too far. NHS lists dizziness and tiredness among common metoprolol side effects. And there is another critical point every family should know. Metoprolol should not be stopped suddenly without medical supervision, because abrupt withdrawal can worsen symptoms and create rebound problems. Medline Plus. That means if this drug is causing trouble, the answer is not panic. The answer is review, tapering if appropriate, and a careful plan. So now let us put these two medications side by side in the way that matters most to real people. If your main goal is lowering high blood pressure in an older body with stiff arteries, and there is no major heart condition demanding a slower pulse, amlodipine often has the more natural fit. If your main goal is protecting a strained heart, slowing an overly fast rhythm, reducing angina, or managing blood pressure in someone with a clear cardiac indication, metoprolol may be the more appropriate tool. That is the medical logic. But daily life is where the difference becomes personal. Imagine two patients. One takes metoprolol and says, "I am too tired to go upstairs without stopping." Another takes amlodipine and says, "My shoes do not fit by evening." Both may be telling the truth. Both may be having a predictable medication experience. And neither experience should be dismissed as just getting older. That phrase has hidden too many medication problems for too many families. If you are finding this comparison helpful, remember this principle. The wrong medication for the right diagnosis can make you miserable. But the right medication for the wrong body can do the same thing. Now we need to talk about a danger that is even more overlooked than side effects: drug interactions. Because older adults are rarely taking just one prescription. Many are taking 4, 6, 8, or more. A heart pill, a cholesterol pill, something for reflux, something for sleep, something for pain, maybe a diabetes medicine, maybe another blood pressure medicine on top of the first one. Every one of those prescriptions may have been reasonable when it was started, but medications do not live alone inside the body. They interact, they compete, they amplify. Amlodipine is metabolized through liver pathways that other drugs can affect, including medications that interfere with CYP3A4 activity. That means blood levels can rise when certain interacting drugs are added. NCBI Stat Pearl's Metoprolol creates a different kind of risk. Its biggest danger is often stacking effects. Add another heart rate lowering medication. Add another blood pressure lowering medication. Add dehydration. Add a smaller appetite and lower body weight than the patient had 5 years ago. Suddenly the same dose that once felt fine may start causing dizziness, weakness, faint feelings, or a pulse that slips too low. This is why medication review should never be one pill at a time thinking. The real question is not only, is amlodipine safe? The real question is amlodipine safe in this person with this medication list at this dose today? Same with metoprolol. Now let us move to the guideline question, because this is where people often want a clean answer. What do experts generally do with these medications? For uncomplicated high blood pressure, calcium channel blockers like amlodipine are part of the standard first-line toolbox. Beta blockers, by contrast, are not generally the routine first choice for simple hypertension in everyone, unless there is another compelling reason tied to the heart. AAFP. That distinction matters, because it means that if an older adult is taking metoprolol for blood pressure alone, with no history of heart attack, no heart failure reason, no rhythm issue, and no angina reason, that prescription deserves a thoughtful second look. Not because it is automatically wrong, but because the why behind the prescription matters. On the other hand, if someone has heart failure, prior heart damage, or a rhythm problem, then metoprolol may be serving a role that goes far beyond blood pressure. And that role may be important enough that fatigue becomes a trade-off worth discussing rather than a reason to abandon the drug casually. So which blood pressure pill is more likely to be draining your energy? In plain terms, metoprolol is more likely than amlodipine to cause the kind of low-energy, slowed-down, heavy feeling people often describe as being wiped out, especially if the heart rate runs too low. That does not mean amlodipine never causes fatigue. It can, but if you are specifically talking about a noticeable loss of drive, exercise tolerance, and overall physical spark, metoprolol is often the one that deserves a very close look. At the same time, if you are asking which one is more likely to cause visible swelling, a sense of pressure in the lower legs, or trouble getting shoes on by evening, amlodipine becomes the more likely suspect. That is the trade-off many families never get clearly explained. One drug may drain energy more, the other may preserve energy better but create swelling that changes mobility. Neither medication is universally safer. The safer medication is the one that matches the body in front of you and the reason the prescription was written in the first place. That is the real answer, not the viral answer, not the dramatic answer, the useful answer. So if you or someone you love is taking one of these medications, here are 5 questions worth bringing to the next appointment. First, what is the main reason I am on this medication right now? Simple blood pressure control, heart protection, rhythm control, or something else? Second, is my current dose still appropriate for my age, my weight, my pulse, and my kidney and liver function today? not 5 years ago. Third, if I am feeling exhausted, dizzy, weak, or mentally slowed down, could this medication be contributing, and how would we evaluate that safely? Fourth, has my full medication list been reviewed for stacking effects, especially anything else that lowers blood pressure or heart rate? And fifth, what signs would mean I should call sooner rather than later? Ankle swelling, fainting, a slow pulse, shortness of breath, worsening fatigue, or falls. Those 5 questions can change a rushed appointment into a meaningful one. And any good clinician will understand why you are asking them. Let me take you back to Margaret. After the afternoon when she nearly collapsed at the kitchen table, her son asked for a full medication review. Not a refill, not a quick yes or no, a full review. Her pulse trend was examined. Her blood pressure readings were reviewed. Her other medications were laid out side by side. And the question finally became clear. Was this still the right drug for the woman she was now? Under Dr. David Lin's supervision, the answer turned out to be no. The medication plan was adjusted carefully, not suddenly, not recklessly, carefully. Over the next several weeks, her pulse improved. Her mornings got lighter. Her walks came back gradually. Then her appetite. Then her interest in life outside the recliner. Her family thought they were watching old age reverse. What they were actually watching was a medication problem being recognized. And that distinction matters, because sometimes what looks like aging is not aging. Sometimes what looks like frailty is over-medication. Sometimes what looks like decline is a side effect that has been normalized for far too long. And sometimes the question that changes everything is very simple. Is this pill still the right pill for me now? If your main problem is high blood pressure from aging blood vessels, amlodipine may be the better fit. If your main problem is a heart that needs protection, metoprolol may be the better fit. If your energy has disappeared and your pulse is low, metoprolol deserves careful attention. If your ankles are swelling and walking is getting harder, amlodipine deserves careful attention. The goal is not to fear medication. The goal is to stop taking medication on autopilot, because autopilot is where older adults get hurt. A prescription that made perfect sense 3 years ago may need to be reduced, replaced, or rebalanced today. And the only way that happens is if someone notices the pattern early enough to ask better questions. So here is the final takeaway. Do not ask which pill is good and which pill is bad. Ask which pill matches the reason it was prescribed. Ask which pill matches the body taking it now. Ask which side effect profile fits your real life better. Ask whether your energy loss, dizziness, swelling, or low pulse has been treated like a symptom of aging when it may actually be a symptom of treatment. That is the conversation that protects older adults. That is the conversation that restores quality of life. And that is the conversation worth having before another year slips by with someone believing they are simply getting old, when in reality, they may just be on the wrong medication, the wrong dose, or the wrong combination. This information is for educational purposes only and does not replace personal medical advice. Never start, stop, or change amlodipine, metoprolol, or any blood pressure medication without speaking to your physician.